Good afternoon, everyone, and welcome to the Baldrige Foundation's Institute for Performance Excellence webinar, Patient Throughput Barriers and Solutions. We will believe that you will enjoy today's webinar, one that will examine one of the most complex process challenges facing healthcare today. Before we get started today, I want to take a moment and recognize all of our great sponsors and a special thanks to the members of the Mac Baldrige Society and our newest member, SANPEC, who all serve as trustees of the Foundation's Institute for Performance Excellence. Here is today's agenda. Today's guests are our facilitator, Roger Spoolman, Senior Advisor, Strategy, Leadership, and Innovation, and co-host of our Leader Dialogue program. Our panelist, Dr. Derek Frique, Chief Medical Officer, Arizona Healthcare, Jake Landsberg, System Vice President of Care Transformation and Effectiveness, Northern Arizona Healthcare, Dr. Chuck Peck, co-host of our Leader Dialogue program, Dr. Darren Frisillo, co-founder and Chief Medical Officer for About Healthcare, and Ben Sawyer, Vice President, Transformation Engineering for About Healthcare. Following their presentation, we will have questions from the audience and a few closing remarks. And now I'm going to turn it over to Roger to get us started.
Great. Thank you, Al, and thank you all for tuning in today. We have a really terrific group of you out there listening, and we have a great selection of people from across our healthcare organizations and across the country. So we're excited about today's webinar. We're excited about our panelists today too, and we did have a little brief introduction by Al. Thank you, Al. But there's really more to these two leaders, our special guests, than we were able to talk about or put in writing here. But Dr. Derek Frique and Jake Landsberg, both from Northern Arizona Healthcare, and these two guys are so energetic and excited about what they're doing. And Derek is the Chief Medical Officer. Jake is the System VP of Care Transformation and Effectiveness. And actually, if we really gave Jake your full title, I don't know how you could put that on a business card, because you've got so many areas of responsibility. It's very impressive. And when our audience gets to know you, they'll know why you have responsibility for all those areas. And then Derek, in addition to being your Chief Medical Officer, you're a practicing internist and hospitalist. That's right. Is that right?
That is correct. I will be seeing patients later this week.
Yeah. And so your insights, and I think most of our participants know that we had a recent Leader Dialogue podcast with Derek and Jake, and it was I loved listening to it. It was not mine to do. It was my colleague and co-host who had the opportunity to do that one. But Dr. Chuck Peck is with us again today. Hello, Chuck. How are you doing?
Good. How are you, Roger?
Great. You look very relaxed. It's good to see you. And then, and as always, Ben Sawyer, our good friend, who reads voraciously and has opinions and knowledge and interested in everything healthcare. So Ben is always a great member of our panel. And so we're looking forward to a great discussion today. We haven't seen,
should be a pleasure.
Yeah, we haven't seen Darren yet, but he, another practicing physician, and that usually takes precedence. So hopefully Darren will show up sometime soon, and he'll always have great insights. Well, let's talk about today's agenda. Well, I do want to get our guests to talk a little bit about Northern Arizona Healthcare, because it covers such a wide geographic area. There may not be the population density of many of our participants, but man, you guys cover the territory, don't you? Which one of you wants to talk about that?
I'll take it. So okay. Northern Arizona Healthcare is located in Flagstaff, Arizona, which is about an hour south of the Grand Canyon, for those of you who know that area. And we're about 2 hours north of Phoenix, Scottsdale area. We cover the entire northern part of Arizona, in that we're the only level 1 trauma center in North Maricopa County where Phoenix is at. And Arizona only has 13 level 1 trauma centers, 11 in Phoenix, 1 in Tucson, and 1 in Flagstaff. So it's a very large geographic area where we cover 700,000 to 800,000 lives and 50,000 square miles. So we get patients from Utah, New Mexico, sometimes Nevada, but not very often, and then travelers from all over the world who come to see the Grand Canyon. It's a great diverse population to take care of. We have a wonderful Native American population, especially from the Navajo and Hopi reservations, but other tribes as well. So we get to see a lot of unique pathology here that you may not get to see in other places. It can be a challenge geographically because of discharging patients, of course, and the distances people have to go, and some of the poverty that exists in the area. We also have our own ground and air ambulance company. And Jake, correct me if I'm wrong, do we have 8 helicopters and 1 fixed wing? Is that right? Yeah, he says, yep. And so we also do a lot of transportation across the area. That's Guardian Medical and Guardian Air, who are pretty well known in the industry. Guardian Air, of course, more than the ground crew.
Great. Thank you, Derek. Yeah, thank you for that. It's amazing how much ground you guys cover. And again, the diversity, as you said, that is really why you two are excellent experts for today's discussion. So we're really looking forward to getting into that. Thank you so much, Derek. Well,
my pleasure.
We're going to follow the process that we normally follow in these discussions. And what we want to do is spend a little time talking about what is the topic that we want to discuss. And that it's barriers to improving health, patient throughput and performance, and then talk a little bit about what are what's impeding health systems from removing those barriers. Then the so what. Why is this important? Why is this sort of universal? Why do we all need to be taking a look at it? And what bad things happen if we don't really pay attention to this and we're not efficient? I want us to make sure that we push through the what and maybe the so what a little bit quicker, because we don't want to leave you hanging. We do want to wrap up with a good, robust discussion about now what. That's really why you're tuning in and why you're participating in today's webinar. What do we do next? And how do you get a handle on and discover new ways of approaching these challenges in the future? So we trust that we're going to be able to give you that in this next hour, a little less than an hour now. So let's go to our first slide on what are the barriers to improving throughput, patient throughput performance, and what's impeding systems from being able to remove those barriers. This seems like a pretty self-evident answer, but it's not, because of all of the variability that each of us have. This is a common thing to health systems, but there's a lot of variability, and the complexity of Northern Arizona health is really a great backdrop for this discussion. So let's think of some examples of patient throughput barriers. Obviously, long lead times, inefficient capacity coordination, and when you have a system, multiple sites, then, Dr. Peck, who has been a practicing physician, also a hospital CEO and a consultant with Guidehouse. He's got a lot of examples, and I'm sure that Chuck is going to bring some of those out about just this challenge of coordination and how inefficient coordination is with regard to capacity and even some of the protocols. Delayed admissions and discharges, what is causing that? Who actually can control that? We have processes that are so siloed. How do we break through those silos and get some more coordination? And inadequate staffing, inconsistent standards, insufficient operational planning. And we always talk about this. We have so much data at our fingertips with EMRs and other things, but we really are light on the insight in terms of what that data really provides us. So listen, enough from me, and let's get right at it. Oh, Ben, you have a question? Go ahead, Ben.
Well, it's more of an observation. When you talk about these kinds of patient throughput barriers, they're all interrelated. They're not separate. Like, in other words, if you're talking about long lead times, it's likely because you have inefficient capacity coordination. Otherwise, the lead times would not be as long. And it could very well be that you're having capacity constraints because you have a lot of delayed admissions and discharges, right? And a high probability of root causal factors is siloed processes. So that's one of the challenges of patient throughput, as every panelist knows, and I think all the listeners know, is it's not single threaded. Every single one of these things relate and work off each other, right? Same thing with the contributions below. You have inadequate staffing, and then it's hard to be able to have really consistent standards when your staffing is constantly changing, and it impacts your ability to have, effective operational planning, particularly if you don't have really good insight coming from your data. Like, you may have a lot of data, but if you don't know exactly what that means and how to apply it. So again, patient throughput, simple phrase, super complex, and all of these things are related. And Derek and Jake, I don't know if you want to comment on that, because you're dealing with that every day.
Yeah. So these examples up here are things that I think every health system or hospital faces. And I didn't add earlier, we do have a second hospital in Cottonwood, Arizona that's a little smaller. And then we have some standalone ER and some other clinics. So we're a system. Long lead times, of course, and that, the back end of getting people out of the hospital and how you move people when you have large distances to travel and all those things. I think everybody understands that. And I think everyone has boatloads of data. And Jake can talk about how much data we have, but then it's using that data the right way and getting people to work together who might understand the data or the workflow in different ways. And so one of the things that I think is really important, and you can take all that data, you can look at it, but if you don't have the right people in the room, you don't have them sitting together, and you don't have them trusting one another, right? Those relationships have to exist between the different people who use the data and then implement it, such as hospitalists, care coordinators, quality improvement people, care transformation people. They don't all speak the same language. And until you get them to that point, it's really hard to cover any ground, because I think most hospitals will say, oh, we have a throughput committee. But it's probably been the same committee that's existed for 5 years, and they try to fix this problem or that problem, but never really have a big impact. And I'll talk about it more in a little bit, but really, to me, leadership is the solution here. Not that Jake and I are the solution because we're leaders in the organization, but it's teaching everyone to lead and teaching everyone how to form those relationships to get this work done. I'll stop there, but I'll talk about it more in a little bit. I'm standing up and I'm kind of excited, so I'll have to give it to Jake.
I think Derek mentioned, we always say here, it takes a village, right? It takes getting the right stakeholders together, from nursing, hospitalists, specialists, IT, education, finance, really a multidisciplinary, approach into solving such a really complicated problem like like throughput, length of stay is. As you mentioned, I don't know a health system that probably isn't working on this, right? Capacity and matching capacity to demand, and throughput, has wide impacts on really a complete balanced scorecard. You think from a quality perspective, from a patient experience perspective, certainly financial perspective, as well. Improving throughput or the flow kind of through the system certainly yields improvements really across the board from a balanced scorecard perspective.
That's great. Thank you. Thank you, guys. I think our audience can begin to see why we're excited about this topic and these guests. And also you can tell that perhaps, if you didn't notice by their credentials, both Ben and Jake are black belts. So they've got that black belt mindset going here and looking at all these things. Well, let's talk about some of these specific things. We've talked about demand, capacity, throughput, technology, and how these things are both challenges and solutions. But what's Northern Arizona? What's been your experience in terms of being able to reduce the frustration for providers and patients and providers alike? So.
Yeah, Roger. So, when we think of throughput, some immediately go to ED, right? The emergency department, long patient wait times. Oh, nothing's moving. It must be an emergency department problem, right? Well, if you look at kind of the information, the emergency department's probably the last place downstream that feels the ultimate impact of poor throughput and just inefficiency throughout the system. So if we can move more upstream and getting patients out, of the hospital, when appropriate, quicker, right? We can also increase and improve that capacity throughout the system. Like Derek mentioned, we have over 400 beds throughout this, Northern Arizona healthcare system, the only regional level 1, trauma center, in the northern part of Arizona. So it's incumbent on us, right? We are a primary receiving facility for many higher level of care patients. So if we don't have the capacity to treat those patients that ultimately need our level of care, that's doing a disservice to the community as well, and not being able to accept patients that need kind of our care and service. You would certainly see it in the emergency department with long patient wait times, right? Left without treatments, percentage increases significantly. So from a patient loss perspective, the impact there, not doing the best we could certainly to serve our community.
And it's particularly important for our community because there is a lot of poverty in Northern Arizona. And when folks have to fly over to go all the way to Phoenix, and now people have a 6-hour drive to go see their family member that's hospitalized versus maybe a 2.5 or 3-hour drive, it's a huge economic impact for those people. And it feels really bad to think that we're sending people so far away. And that's so important to explain to people when you try to get different people within the system to work together to solve this problem, is to remember, what is it we're trying to accomplish? We're trying to accomplish taking good quality care of patients and make sure that they're close to home and they don't have to go a long way. And when you can have those conversations with people and get them back to what our real mission is, that's that first step in getting hospitalists to work with care coordinators, to people seeing things that can be done a different way. We can change the way we do things and we don't have to be so set in our ways. And it's important to give people that mission and that why when you do that. And that's part of what Jake and I have been doing, is really facilitating those relationships between different leaders. My hospitalist director is a great guy. He's relatively new to the role, and having those conversations with him about saying, you don't have to always tell people why you can't do something, right? Because then you're always the barrier. You have to think about how you can do something and why that other person you're talking to may be right, not always the reason that they're wrong, and be open to those ideas, because ultimately you might find yourself having a better work life if you can be more open to those things and you're not everyone's barrier. It's a really tricky part of this, probably the most complex part, just getting people to sit down and understand one another.
I was thinking, Derek, about the broad geographic area that you all cover. And from a patient perspective, because it's so, you cover all this rural area in addition to your urban area, boy, they've been treated, they've been seen perhaps by their primary care doc or by an urgent care center, and they've tried to get a hold of, what's the real problem? How do we fix it? And then they say, well, now we're going to send you to the hospital. And so the expectation on the part of the patient is, oh, good, finally, they're going to figure this out. So the expectation is very, very high, isn't it?
Well, it's tricky too, because what will happen a lot of times is maybe someone comes from in town. That's a little bit easier. We have about 80,000 people in Flagstaff. Or someone comes from far away, and they come from far away with the expectation that they're coming here. I'm coming here to see the cardiologist.
Yeah.
When in reality, they don't even need to see a cardiologist. So you have to work with people in a way to make them feel satisfied with the care they receive, having traveled a long distance to get that care. There's a lot of patient satisfaction, consumer satisfaction that you have to work with in this geographic area. I know that sounds crazy, but people have an expectation, just like you said. And, oh, I was sent here to see the cardiologist. Okay, well, I'm going to talk to my cardiologist colleague and I'm going to give them that why, and they're going to come and do this, and they're going to be gracious about it. That's a lot of the work we do here sometimes, is just that satisfaction piece to make people feel like they've received what they needed to receive, even if it's something they didn't necessarily need, but they traveled that distance for it.
Yeah. Chuck?
Yeah, so Jake and Derek, I think there's one other thing that I've observed, and I'd like your thoughts about this too. I think that there's this assumption or notion that the hospitalist, when you're talking about admitting a patient to the hospital, that the hospitalist has to be in charge of everything. And I think that, I'll just use an example. So if you look at organizations that have an integrated practice unit structure around something like heart failure, where they actually have a heart failure specialist on that unit working along with the hospitalist. And if you compare a unit like that to a unit of heart failure patients just with a hospitalist who may be well trained in everything else, but doesn't feel as comfortable using the newest and best protocols, high dose Lasix and things like that, there's a dramatic difference in length of stay, quality, patient satisfaction, readmission, and everything else. And so, I hope as we go through this, you'll talk a little bit about how to stop thinking about the specialist as just the consultant, but rather more fully integrating them into the approach and thinking about care and patients more along the line of disease and diagnosis as opposed to just location.
Yeah, so this integrated type model you're talking about is fantastic. And part of that has to do with where you place patients and if you can get them geographically placed, and Jake can expand on that a lot. But some of the challenges we have here are that we have a specialist group for each specialty because of the geographic location and the size of the community. So in our organization, the hospitalist does have to drive a lot of that care. So our hospitalist group is one that prides itself on managing that care more than they would in a larger city where there might be multiple competing specialist groups that want to get that business and come in and do it. I think the model you're talking about is the optimum model. My goal is to do less work. I want to have that interaction with my colleague that's going to come and drive that care, teach me, also learn from me, work together and figure out how to get people out on the back end. Because one of the things when you're talking about readmissions and having that faster throughput or less length of stay, where we fail so often is in the discharge process. When we discharge people, we often think about their discharge. Now they're no longer something I need to worry about, but there are so many pieces that really aren't that time consuming that many physicians do believe are time consuming that you put into that last step of getting someone out of the hospital that sets them up for success and keeps them from coming back and opens up beds for a later date. But Jake, you can talk a little bit about that.
Yeah, I think Chuck, you bring up a really great point. Around variation, right? One of our goals, from a quality, safety, efficiency, timeliness, effectiveness, perspective is really reducing that unwarranted variation in care, right? So if we have standard kind of care models or care pathways for how to treat those specific patient populations that you mentioned, and that's where the data, really turning that data into information helps us to understand where are there large degrees of variation, right? If the average is, 3 days and, you have a really big standard deviation, that means a lot of different people are doing things differently. And that could mean patients staying 3 days or a patient could stay 6 days, and if we could standardize that care model and those care pathways, right, that leads to better, more high quality and consistent care delivery for those patients that ultimately need our service.
And heart failure is always that classic one, when do you switch from intravenous to oral? How long do you keep people there until you feel that they're at their dry weight or they're going to be at their dry weight? And the care models for heart failure that I think evolve often are the best example of how that can be utilized, that integrative care model you're talking about in standardization.
Right. And I'd say, you can't create that in a vacuum though, right? If cardiology just wrote a care model, told nursing what to do, same with hospitalists, that probably wouldn't go so well, right? So again, that's why we really need to bring the right stakeholders to the table, identifying really what is the pathway, using, literature that's available, right? Other systems, best practices, and really modeling it out as far as, discharge planning should happen on day of admission, right? So on days, if we're planning to get a patient out in, 3 days, right? What has to happen on day 0, right? Day 1, day 2, day 3, by all of the different stakeholders involved in that patient's care. And then of course you need the information to be able to monitor how are we performing to those metrics, right? Where maybe we're missing something, are our interventions, have they been effective? And then, of course, how do you sustain those improvements, right? It's one thing to make, a 50% improvement, right? But we know, you mentioned earlier, a lot of different competing priorities, and it's easy for some systems to fix something, turn their head, and then, a couple months later, they're right back to where they started. So that sustainment piece is really, really important.
Easy to tell Jake's a black belt.
Yeah, I'm going to move.
But no, real quick, but I just one quick point on that. We tried that before Jake came. We had one person who wrote a bunch of care process models, and the problem was they were siloed. Other people didn't have input. They were so complex that they were difficult to use, and so people didn't use them for multiple reasons. And that's the whole thing about having stakeholders. But please go ahead.
Yeah, great. Thank you.
So I have
to the next slide, Ben.
Okay, and I just had a quick question in that regard, Roger. So, Jake and Derek, you guys have talked about how you're approaching this from a system standpoint. You've talked about ED challenges, you've talked about clinical pathway challenges, et cetera. How do you look at it systematically? In other words, when you're talking about ED challenges, what things are you doing to optimize those inputs and optimizing the outputs, like with PAC, and really starting to sort of decompress, like in capacity strains here on this slide? What are you guys doing in kind of an innovative way to address these kinds of challenges that so many health systems are dealing with?
Yeah, I'd say, Ben, kind of two main strategies. One, to really focused on improving capacity, or at least matching demand to capacity. So actually, one of our system kind of board level initiatives from a quality safety perspective is around throughput, right? And it's a two-part measure, really looking at reducing patient length of stay. We used geometric mean length of stay percentage, which is really just how long the patient stayed over how long they should have stayed as an index measure. And then the second piece of that is really the timeliness of discharge, right? So at what hour of the day, we use 1 p.m. Here, what % of those patients ultimately left the hospital or their hospital room by 1 p.m. And if we can shift that time up earlier in the day, and if we can reduce kind of how long patients ultimately stay in the hospital, right, it ultimately improves the capacity, of available beds for patients that need our care, whether that's out from a different, outlying facility, or patients that are currently waiting in the, in the ED. And when you look at kind of what %, how we knew we had a problem is around 50% of our bed demand comes by 1 p.m. but we're only moving a little less than around 30% of our patients. So automatically, in the beginning of the day, we're already set up, behind the ball, 8 ball, where we need to be. So really putting that laser focus on those two key areas, we feel will help improve capacity. And certainly you'll see downstream impacts in quality, safety, experience, and finance as well. That's really where we've been focusing our main efforts. And we have a ton of strategies around, how we're accomplishing those two main focus points.
That's helpful. Thanks, Jake.
Thank you, Jake. Hey, I want to get us to the, this is the what now, is the so what. I want to get us to that. But before we leave this slide, in two things. We have a question from the audience about the importance, mentioning the importance of understanding the customer or the patient value stream. And I don't know if anybody wants to tackle that. But also, before we leave this slide, are there any other impediments that you all have found that are not listed here, or anything that you think our audience might be curious about or find helpful?
No, I think there's certainly no shortage of challenges, right? Roger, like you mentioned, from an experience perspective, like we mentioned, you go back to Lean Six Sigma, one of the tools is really the voice of the customer, right? What customer wants to wait, right? Especially waiting in, an emergency department or, something like that. I have the privilege of also leading quality safety for the organization. And as much as we try to prevent errors from happening, right, still bad things can happen, in a hospital. So the longer we prolong that patient length of stay, right, we're not only increasing wait times, but also, the probability that one of those unfortunate events, happens. So there's many impacts, certainly to the patient and the patient's experience.
And I'll brag on Jake a little bit. When Jake took over in his role, Northern Arizona Healthcare's 2 hospitals were both Leapfrog grade D, and they are now both Leapfrog grade A. And that's the work that he's done. There are 5 grade A hospitals in the state. We are 2 of those 5. So it's the work that he's talking about. It's legit and it's been done. So I just want to mention that because it's a little to give him some credibility.
Congratulations. Way to go. Way to go. Just one.
Certainly takes a village to get there.
Yeah.
But I appreciate it, Derek.
Appreciate your humility. That's good, Jake. Any managed care organizations delaying discharge? Is that ever an issue with you guys?
It's becoming more. It's becoming much more of an issue this year, I think. Don't you think, Jake?
Yeah, certainly with the public health emergency being discontinued, right? The SNF waiver, certainly that had helped kind of facilitate faster movement of patients. But we see the biggest difficulty in moving those patients that really do need post-acute services and getting the auth, right? Dealing with the payers. That's certainly a very long component in the total, cycle time.
The prior authorization's been just killing us lately because we'll have all these patients need to go to skilled nursing. We only have a limited number of skilled nursing facilities in this part of the state. And I'll wait days sometimes for a patient who has been medically stable and ready to go to get that prior authorization done. That's a real killer on Throughput for sure.
I think those answers are even more reason why you focus on the patients that you can control. Because there's some of these things are just out of our control. So let's at least try to focus on the patients we do have control. Patients who, if we do the right things at the first day, are ready to go with help at home, with care at home. Let's focus on those people because this battle with the insurance companies is never ending, right?
Absolutely. Right. Really focusing on those patients that don't have many needs, right? That are, routine discharges, and Chuck, to your point, that's ultimately starts on day 0. I mean, if we can help understand where this patient's going to, go post-discharge, and we have really, we have a great care coordination team throughout the system, and they start discharge planning day of admission. Right. And not only do they create a plan, but we also have a backup plan. And we're messaging and tracking progress to that plan really every day and bringing those the care team together to identify any changes, any barriers. But that starts with proactive, planning and keeping everyone, aligned around that patient's discharge plan. If we just find out tomorrow, they've been here for 6 days and they're going to a SNF, well, unfortunately, we're already 3 days behind, in moving that patient and getting them discharged.
Well, as we can see, there's no shortage of challenges, and I love the way that you guys have really tackled some of these. So now we're in the so what portion of the webinar, and so let's talk a little bit about the real implications, behind this. And why is it so important? Well, we've been talking about some of those issues right now. It does drive capacity. It impacts capacity tremendously. And it does determine productivity and the efficient use of your staff. We didn't talk about staffing issues. It seems like that's a topic that always comes up, but it certainly impacts the efficient use of your staff, doesn't it?
Absolutely.
Yeah.
Great. I'm
sure.
Oh, go ahead, Roger.
Oh, no, please, you're the guest. Go ahead.
No, I'm sure many health systems have measures of productivity, right? Many of the nursing units either use, equivalent patient days or, total admits, registration. So, getting those patients and those patient days through, to the actual unit rather than them sitting and boarding in the emergency department, to your point, certainly drives productivity, but that's certainly an impact, but I'd argue the quality safety piece certainly outweighs that.
Yeah. Yeah.
And I look back at that slide before where you have crisis and change on there. And culturally, I don't think I can stress enough the importance of what this slide looks like. We've got a lot of people that have to contribute to this. As Jake says, it takes a village. I talked about earlier how we have all that data. Getting people to feel like they are the people implementing change, that change is not being done to them, is one of the things Jake and I have had to work very hard on. Jake and I get along really well, and it's easy for us to understand it because, of course, people who make the change are the people who love the change, but it's getting the people that are the hospitalist director, the care transformation people to sit down, talk to each other, and accept and trust what each other are saying, to get them to build relationships so that they will go work on this together and take it down to the front line and let the frontline people actually develop the how you're going to do things from the what and the why that you give them strategically. That is one of the most critical things we've done. You can get down into the weeds about how do we get this person out the door? How do we get this person sent back home? But if you don't start with the relationships that have to exist between the people who have to work together to make this change happen, it will not work. And I actually would say, I think that's probably where most people fail at this, is the leadership aspect of not getting people to work together, trust one another, and get to implement the change themselves. I just wanted to touch on that because that slide is so much more poignant than just a little Scrabble thing. There's a lot there.
Thank you for bringing that up. I mean, empowerment and engagement, we know, are just incredibly important, and we could spend definitely hours on just culture alone. And I think the communication that you have between your caregivers and the patients and what have you, I mean, that gets at some of these issues, these very, very specific issues.
Derek, it gets to, I think it's key to the virtuous cycle, right? If you have the trust, then you'll have the commitment. And if you have the commitment, then you'll have the accountability. And if you have the accountability, you'll get the result. And if you remove any one of those things, you won't get it.
And if you have trust, the real trust that has to exist for everyone to be able to lead, accountability is not even a thing because people hold themselves accountable to be successful for their leader or for the organization that they trust and care about. It's nuanced, but it's so important to this. It's the culture that has to get this done.
That's great. That's great. Hey, I'm just looking at a question that came in from our audience and asking, Jacqueline asks if it's possible to share examples of care coordination plans for commonly seen discharge DRGs. Maybe this is a good place to stick that in because, again, it's clearly a patient throughput issue. I know, maybe between Derek and Chuck, maybe you guys have some thoughts about this.
Well, yeah, I mean, I wish I had the data with us so we could show you. I know Jake has that data, and actually we're working on something like that right now about taking those particular DRGs and figuring out just a few things that have to take place to make their discharge more standardized with care management. But it goes to me, I don't have it with me right now, but it goes kind of back to Chuck's point earlier about that idea of having that integrated care model where there's one particular unit that does that work and how well that could work in a good system. I don't have it with me. Jake might have some of that data. He tends to pull data out up very quickly, but I don't think he's probably doing it now.
I think at a high level, we have certain structures from like a quality safety perspective that help enable, getting the right stakeholders together, right? So we have, similar structures, clinical consensus groups that are within our our clinical executive council, how we lead quality safety, timeliness, efficiency, effectiveness across the organization. One of those main points is around clinical consensus. And for our major service lines like cardiology, ortho spine, primary care, hospital medicine, getting that team together to identify, hey, we're seeing a lot of variation in these, in these patient populations, right? Like our cardiology clinical consensus group is actually working on reducing variation within heart failure patients, right? So that's DRG 291 to 293, right? They're staying this long, our goal is this, and further breaking that data down, identifying what are the key drivers barriers there. And again, designing those care pathways to really reduce that unwarranted variation. That's one example within kind of the cardiology structure, right? But many of them are also addressing kind of those patient populations that are predominant within their service lines.
And Jay, could you also just touch on how important at the beginning of all this work that you did was role clarity? Because another thing that, you know, I see a lot is that there's a lot of confusion around whose role it is. Is it the hospitalist's role to refresh the expected date of discharge every day, or is it the care coordinator? And, you know, if each person thinks it's their role, what happens is 4 days go by and nobody does any of the refreshing. And then before you know it, the length of stay is now 3 days longer than what it was supposed to be.
Yeah, yeah.
That's oh, go ahead, Jake.
No, I mean, that comes back to the village piece of it, right? You know, you got to have clinical documentation, you know, involved to assign, you know, a working DRG. That working DRG drives your expected length of stay. That expected length of stay is really the goalpost that the care team's working to deliver against. But to your point, Chuck, you know, if people don't understand where that number is coming from, or, you know, even basics, right? I mean, we're assuming that the whole organization knows even how length of stay is measured, right? And, you know, there's a ton of nuance around that, you know, inpatient only, GMLOS, right? What the heck is that? And, you know, as we're leading change across the organization, really important that people understand, you know, how something is measured, right? Why we measure it that way, so they can ultimately help us win, you know, collectively. If teams don't understand, you know, how performance is ultimately measured, right, it's going to be incredibly difficult for us as a system to demonstrate improvement on that. So, you know, that kind of goes back to the role clarity piece of it, of just helping people understand, you know, first and set a really great foundation that we can build upon. And, you know, oftentimes I see that foundation is either assumed to be there, right? And if you're missing those gaps, it's just going to delay progress ultimately.
And
so
that,
Jake,
that's,
there.
I was
sorry.
just going to expand on that with Chuck real quick. That ownership piece is really important, because when people don't know what they own or what they're supposed to own, things do get lost. And we're going through that right now with the hospitalist, trying to get them to be the ones that put in a readiness for discharge order the day before the person goes, which then triggers a lot of things that the nurses do to have that person ready earlier in the day. And we really have not done as good a job yet where we can explain to the hospitalist, look at what this does for your day when you get this order put in, and look at the successes that happen for the group and for the patient when you do this, so that you know it's a priority, so that we don't have half the group doing it and half the group not doing it. But it's so much of that why it's important to not just the patient, but to you, helps drive that ownership piece. And that's something we're really trying to work on a lot.
So there are two audience questions that are related exactly to what you guys are talking about. So let me just surface them. One is clarity on the change management process you're using. And the second is which top 3 to 5 metrics would you say are pertinent to follow for a hospital-wide patient flow committee? So those are two questions that came up in the
Okay, chat. I want to talk about change management.
Go.
I hate the term change management. It's this business term that we use, and we have consultants that we say, let's bring in the consultants to help everyone understand the change. But then when you bring those consultants in to help everyone understand the change, they say, I don't know you, why should I listen to you? And it's difficult. So this goes back once again to leadership development. You train your leaders how to lead. You train because it's a skill, right? You train leaders how to lead. You teach them how to form relationships with their subordinates, both up and down the chain of command. And if you do that, and you do a decentralized command model the right way, where you're able to explain strategically the what and the why, once again, and your people develop the how, then your people are the ones that are actually developing the change. And if it doesn't work, they own it and they go back and fix it because it's their plan. Change management is a complicated term that is really just about relationships and trust. Yeah. That's the model that we use. But Jake, go ahead.
No, I'd agree with Derek. I mean, there's many different kind of models for change, and, you know, I'm a big Cotter fan, you know, as well. But ultimately, like Derek mentioned, it doesn't have to be overly complicated, right? If you include the people that are doing the work every day, right? Those closest to the work understand what needs to be changed the best, right? You get the group of stakeholders involved. and empower them really to make that change. And if they understand the why, right, and we can communicate the what, you're going to see success, right? And it's really as easy as that, but as easy as it sounds, it's really difficult to do, as well. And that's why, keeping the team aligned, keeping them focused, on the end goal, celebrating those successes, right? Even if they're little wins, and ultimately the support from leadership to make the change that we know needs to happen are probably some of the key components that I'd say have led to much of our success throughout the organization.
And keeping them aligned is so important because it's so easy. Human nature is for you to back into your team, into your silo, and not collaborate. So that's a lot of the work, is keeping them all engaged and keeping the transparency there with the processes and how we develop them so that people feel okay with it. Because the second they don't feel it, or they don't feel that trust, they back into their silo, back into their team, and they're fighting everyone else. They don't want to take that ownership of that piece because they feel like it's too much work for them to do. So it's so much of the communication here.
Great practical wisdom, guys. Thanks. Hey, Ben, could we go to the next? This slide, I really like this slide, but as I reread it, as I read these 9 significant external forces at work across healthcare universally, this isn't regionally or anything like that. But as I read each of these, and I just refer them to you for your future use, but there's nothing new here. Getting old, patients are getting older, their needs are becoming more complex. So complex care, alternative care settings, higher expectations, high volume centers of excellence, complex care needs to go there. Availability and expectations of work. It just occurs to me that all 9 of those things, now I don't want to be simplistic, but just what Jake and Derek, what you've been talking about, these things are just wonderful topics to discuss among the multidisciplinary care teams and say, what do you think we should do about this? Is this an important thing for us? What solutions do you guys think we should come up with, or how should we approach this? Right? It's not that difficult, and that's where good answers are going to come from.
Those people know, and you're absolutely right. It's not it's easy to understand. It is difficult to do. It is difficult to give that power away and let those people develop those plans, but you won't be successful without it. Those are the people that understand the workflow. The multidisciplinary team are the people you need to ask for the solutions from and make sure they understand they can fail. But that's the key to all this. It's just getting yourself to not work the normal way and go against your human tendencies to control things and let other people guide it. All these things on here, great examples of things that either we're working on or every health system in the country is working on, and they're all going to be different in 2 years. But the people are what make it happen and how you interact with them.
Yeah, and the solutions aren't necessarily going to come from outside consultants. You've got great solutions internally. Just got to ask your people and listen to them.
Yeah. Well, we've had a great relationship, and I don't know if Darren's on here or not, but with About, and they've been extraordinarily helpful for us from a very technical expertise standpoint, from giving us talking points about how to do things. But really, a lot of the work that we've done with About in our transfer center and bringing people in has really been done by my wife, who's the transfer center medical director, or she's a hospitalist as well, and with her team of nurses that have been driving all that change. They're the ones that are working on that, and they're doing that internally with great advice from someone like Darren.
That's great. That's great. Good information. Please take a look at this, the now what, and let's give our audience some of the benefit of your experience, guys. And what's kind of the best way to get started? If you're stressed and frustrated by this, what's the best way to give them some advice about how to get started?
I'd say structure. And Jake, you're the best structure person I've ever met in my life.
Yeah, I mean, I think you need ultimately vision, structure, and strategy, right? So, where do we want to go? Overall, we can't, we will never be successful in, improving health and healing people, which is, Northern Arizona's, mission, if there's no capacity, right? I mean, like I mentioned, we serve the northern part of the state. People come to us because they need the level of care that we can provide to the region. And we're obviously unable to deliver that higher level of care if we don't have the bed capacity to do it. So like Derek mentioned, having that the structure, right, the effective structures as far as governance, decision-making, right, engaging the frontline, staff, the right stakeholders, bringing them together, and supporting that, right? That takes resources to support, as well. We have a great care transformation team, from process improvement specialists to industrial engineers from a, process engineering perspective, some project management resources as well. And it really takes the whole care team, right, with those support structures to be effective and ultimately enable that change that can be sustained and that's long lasting. And the leadership piece, right, like Derek mentioned, getting the leadership aligned, having them under a clear understanding of the why, right? Why are we doing this? Why is this important? How is it measured? And then what needs to change, and how do we kind of collectively move in that same direction? And that's going to create success, right? No matter if you're talking around improving throughput or whatever measure, is on your scorecard. I think one of the questions was, what are the top 3 measures? I think looking at, some observed over expected measure of length of stay performance, we use geometric mean length of stay. We're obviously looking at our observation length of stay in hours, and that timeliness of discharge, and also some of the ED measures as well, right? Like admit patient, boarding times, certainly looking at left without treatment rates as well. Those are probably the key measures, the big high level ones. And of course, you could peel those down to certainly understand more within that cycle. But those top 5 will tell you pretty quickly how efficient and effective and timely the health system's performing from a patient throughput and flow perspective.
And to Jake's point, teaching, there's technical know-how everywhere. Now, not everyone has a Jake. In fact, no one does, but there's technical know-how everywhere. It's educating your people and teaching them about leadership, about how to truly lead, about how to own things, and to not be afraid to own things and learn how to prioritize their work. We invested heavily in leadership development for our organization. And Jake and I were just going through the data on our engagement survey on this. Our group of supervisors, managers, directors, so really the people, the real leaders in the organization, we saw their engagement with the organization and the work they do go from the 60th percentile as a group, which is pretty good, in 1 year to the 96th percentile, because we invested in that group of people and they're learning skills now to take that technical know-how and do something with it. And I think that's where most health systems fail, is we have these people that are, you're a good nurse, you must be a good leader. You're a good doctor, you must be a good leader. And we promote people to places where they don't know what to do. And it's not that they don't have the intellect to do it, it's they don't have the skill set. But right. We find when we get them the skill set, then things start to happen because they understand the technical aspect of it, but they don't know how to implement it.
Hey, Derek and Jake, there's another question here that goes back to something you said earlier, or talking about earlier, Derek, and that was the transfer center, and how big a role the transfer center plays across the system. Do all patients come to your quaternary center? I think you mentioned that you had one other hospital, Cottonwood, and do you transfer less sick patients back to them through the transfer center? What exactly does the transfer center do aside from potentially, facilitate transfers from other places?
Right. So you think about it's one department we call clinical care operations, and it houses the transfer center the bed board, all these different little departments, but they really are they're the people that are figuring out the puzzle all the time. And when we run at a high capacity, they're the ones that are trying to help us place patients geographically, et cetera. So they're so important because we do have to utilize our other hospital. So one of the things that we've done with and with my wife, Catherine, is develop that single provider acceptance model, which she put an incredible amount of time into. And once we developed that single provider acceptance model, our admit times or time to transfer or time to yes went down dramatically. And then we use that transfer center to place people strategically. So for example, we don't have neurosurgery at our smaller hospital, but we do have it here. But we do have good hospitalists and we have infectious disease. And so maybe someone's transferring with sepsis and pneumonia. Well, let's send them to the bed at the smaller hospital where we have people who can take care for them and leave our beds open for maybe that neurosurgical patient that needs to come. Using your beds optimally is so important. They don't just bring people in. We're learning to bring them in strategically and use our beds the best way so that we don't have our Flagstaff hospital full and our Cottonwood hospital half full, and some of the patients in Flagstaff could be taken care of in Cottonwood. They're already traveling a pretty vast distance and we're only about an hour apart. So using our beds the right way is a lot of what we're getting the transfer center to develop. And that's with a lot of help as well.
Sorry, Ben.
No, it's fine. Just quick question.
Go ahead.
You were speaking earlier, Derek and Jake, about the relationship you have with and I know that you've been working closely, for example, with Lane Wise and Reagan McCone on kind of a quarterly business review where they're coming alongside and helping to provide some insight. Can you just talk to the audience about partnerships and how you can leverage those to help you in terms of your operational performance?
Yeah, I'd say, Ben, I've been through many quarterly business review meetings, and probably the one with About is one of the best. I found they're super responsive. They really are partners with us, right? They understand kind of where we're headed as far as improving throughput, improving capacity, right? Effectively using the transfer center resource, like Derek mentioned, and extremely responsive. So if we have questions and, hey, what about, this, can we look at this data, building those custom reports for us, it's been really helpful for us to demonstrate success in improving throughput and capacity management. So really some great tools and resources and people that we've had the pleasure of working with.
Great. Thanks for that clarity, Derek.
I'm just taking a look at our time, and I want to keep us on schedule here. You guys have been amazing. I do have, and we've been able to answer a lot of the questions, and we will answer others. People will have opportunity to get the slides. Al will make sure that that's available to you, those of you who've pre-registered. And then I just have one final question. Maybe somebody can answer this in about a minute or less. At the end of the day, who really owns patient throughput?
We all do. It's everyone owns it. And that's the attitude you want people to have, is that they all own it in some capacity. But then when it really comes down to it and things don't work, Jake and I own it because we're the ones in charge.
Yeah.
Leaders have to own everything.
Yeah, I would agree. I mean, I think everyone owns it, right? But, the counter to that is when everyone owns it, no one owns it, right? So to the earlier point of everyone contributes, right? But it's incredibly important for people to understand what is their primary role in a really complicated process like effective, movement of patients, right? And if they understand that piece, that's probably 80% of the challenge, Roger.
That's great. Well, that's a great way to end this fascinating discussion. What a great, energetic roundtable we've had, Derek and Jake. Thank you so much. Congratulations. I hope our audience realizes that this isn't just a couple of guys in an organization that was really hitting it out of the park, and they're just now hitting it further out of the park. No, your health grades, your leapfrog D to an A. It's amazing what you guys have done. Congratulations. Well done. You're an inspiration. And thanks for taking time to be with us today. And to our audience, thank you. I'm going to turn it back over to Al to close us out.
Thanks for having us.
Roger, Derek, Jake, Chuck, and Ben, Thank you for such an engaging and informative discussion today. That was truly outstanding, as Roger said. As a reminder to everyone, the Foundation's Institute for Performance Excellence has more than 400 training and professional development certification opportunities offered online and at your own pace. This month, we are showcasing two of our most popular online courses, Supply Chain Management and Lean Healthcare Professional. You can visit the Institute at baldrigeinstitute.org/education to learn more about all of our courses and to register. Thanks again to everyone for attending today. As a reminder, the recorded version of today's presentation and the slides will be available on the Foundation's website early next week. And once again, thanks to all of our sponsors, especially the members of the Mac Baldrige Society, who are the trustees of the Institute for Performance Excellence. It is their generous support that makes presentations like today possible. Thanks again, everybody, for tuning in. Please be safe and have a great day.